Welcome to the Daily Apple. I'm your host, Kevin White. Emma Ryan and I will dive into all topics related to the science of longevity, along with some other subjects we just find of interest, with the hopes to provide useful information for everyone. This stems from my personal interest to optimize the human condition, to not just live longer, but to live better. Anyway, hey everybody, welcome to the Daily Apple. In this session, I get the opportunity to visit with the great Dr. Suzanne Ferree, who I have nothing but the greatest respect for. And one of the reasons I wanted to have you on today is because there's continually so much interest about peptides and just kind of talking about those a little bit, how they interact with us, especially in the realm of performance enhancement and longevity as well. And then I want to talk a little bit about some of the other stuff that you're into that we talk, about neuro stuff with Procaine, which is pretty exciting. And so I get kind of giddy about this, but this is pretty cool. But anyway, a little bit more about you. And one of the reasons I have a lot of respect for you is because your knowledge of peptides and the way you really know what you're talking about. Whenever I first heard you lecture about, 4 years ago or something. And I asked you a question. I just thought about this. You may not remember, but I asked you this question about, we were having this conversation and I said, if you could have $1 billion, but you'd have to be 80 years old, would you take the money and, magically be 80 years old? And the idea is it puts value on our longevity and everything, right? So, but you said something I didn't expect. You said, I kind of feel like we're all going to leave this life eventually, and I could do a lot of really good with that money. And so I'd take it. I'd probably just take it. And I don't know if you still feel that way, but I thought, wow, you're a different breed of cat there. It just made me impressive about, for somebody in the longevity space, we all value all that, but you have a different play of, in your belief system and everything. So,
well, we also talk about the fact that when people are 80, they don't have to be without activity. I mean, I have 80-year-olds in my practice that are still playing golf and out and being active. And, it's the ones that maintain their activity level that are still able to do the things they want to do. And a lot of times they're playing sports, they're being with their family, whatever that looks like, and traveling. And just because they're in their 80s, we met this adorable couple. I just went to Austria for 10 days. And while I was on this trip, this really cute couple was there and they were in their 80s. They had just met and had been dating for 6 months. And this was their first trip together. Well, you would never have known they were in their 80s when she said, yeah, I'm 83. And she was so lovely and active. They did every single thing that we did the whole week. So that was great. We had a really great time with them. So if that's the 80-year-old I'm going to be, absolutely. Let's do something great with the money and let's skip it over. Yeah.
Well, yeah. So I guess we'll just delve right into it. And I guess we should frame it with, obviously, let's talk a little bit about what peptides are. And you and I both know, and I feel like everyone should know this, but just for the framing, setting a foundation, why don't you just kind of tell us kind of what peptides are and give us your spiel on that?
Sure. So peptides are strings of amino acids. By convention, we doctors call anything that is less than 50 amino acids in length. And amino acids are things like leucine, valine, threonine, there's tons of different kinds of amino acids, glycine, lysine, cysteine, all of these are put together in a specific order. And based on how the order of those amino acids goes, they do different things in the body. And so much like a complicated lock and key and how each one of us has a different lock on our home and the key must fit that particular home, the same thing is true for these various strings of amino acids. A different string of amino acids will provide you with a different signaling molecule in the body. So now the cell responds in a different way based on what the signaling molecule is telling it to do and the lock or key that gets put into that lock on the cell. So these are strings of amino acids by convention that are 50 or less amino acids in length. If they are over 50 amino acids, we call them polypeptides. If they are over 150 amino acids, we call them proteins. So you're familiar with protein. Think about a chicken breast that's got protein in it. So these have been around for, obviously, they're as long as life has been around. And when we find that the body breaks these down into smaller and smaller fragments, and the ones that are about 40 to 50 amino acids long, that's what we call peptides. The original researchers were in the 90s looking at intestinal peptides that trigger various responses in the intestines, secretion of the mucosal layer on the intestines, stimulation of appetite, decrease in appetite, current familiar GLP-1s, the peptide oxytocin, which many of you are familiar with from pregnancy when you are trying to stimulate contractions of the uterus. This peptide has so many functions in the body. And so each of them has its own function depending on which cell line it's signaling. So as it goes to the cell, binds to its receptor, does its job, every cell will respond a little bit differently. And there are receptors for most peptides on most kinds of cells, depending which peptide you're talking about. So that's what's exciting. We can get responses in the muscle, we can get responses in the tendon, we can get responses at the liver, in the pancreas, in the brain, based on what that particular peptide is responsible for doing. So it's exciting to have all these options. And as researchers are discovering more and more of these signaling molecules, we're learning more and more about what the body does, and particularly at the cellular level, what things we can do. So a few years ago, someone figured out how to, I think it was about 15 years ago, figured out how to make these in a lab, a synthetic peptide in a lab in a safe way. And so now also in a way that we could get large volumes of them so that we could produce them for commercial use. And that's what's happened. People are asked all the time, why are peptides so popular now? It's because we used to have to get them from a cow or a pig or another human. And now we can actually get them synthesized in a lab in the exact same amino acid sequence as they would be in your body.
Yeah. So that brings me to, I mean, because I've read your book and
Thank you.
Yeah. And I would really recommend that to anybody who wants to understand that, because you do a really good job as far as in the book Counterclockwise that we're talking about by Dr. Ferree. You go into detail on what you just said, and you also make it every chapter is like personalized based on a specific patient, which makes it easy to follow, because everyone can identify with that. So you really go deep into the science of all this, and then specifically on energy, cognition, performance, weight loss, all that stuff. So that's what people want to know about. So anyway, I think it's a great blueprint, for somebody to refer to.
Thank you so much. It's designed to be read either cover to cover or just one chapter. So if all you have is a gut problem, you can go right to the gut chapter and just read that chapter and ignore the rest of the book. Although it all ties together, and you probably will want to ultimately read all that's available, it is designed in a way that you can just read the relevant chapter to you.
Yeah. So as far as performance, I've got a guy that I'm just going to tell about stories here. He did worlds for CrossFit. He's 62 years old. The guy's in fantastic shape and really dialed in. His LP is kind of high, so he had a cardiovascular event like 4 or 5 years ago. But we started him on just BPC 157. I mean, he's got some hormone stuff that we've adjusted physiologically, which he's always been on that for many years. But this year he did just the BPC 157. And I mean, not much of a stack, just one thing. But he texted me after his training, because he does this every summer. And he said, I wasn't sore at all. I totally tolerated my training. It was just great. And he went and he was supposed to get first. They got robbed. They got second because there was some kind of, anyway, I won't go into those details. He was pretty frustrated, but he wants to work very closely. And he goes, I want first next year and we're going to go do it. But and that's just one of many, just with that one peptide.
Did you do it orally or injectable?
I did injectable, and I know there's been some issues getting him, but we've still been able to finagle that. So anyway.
Well, the FDA has come back out and turned around some of their concerns, which is really exciting for us, because that means our compounding pharmacies can make them again. So I'm not super concerned about not being able, there's 2 I know of compounding pharmacies that are making it now. So that's exciting.
Yeah. So we're going to be doing like a different stack. He's totally excited about it. So, But yeah, so
And when we talk about stack, sorry to interrupt, when we talk about stack, we're talking about using 3 or 4, somewhere in that range, peptides together in the same sequence. So you would often, we talk about using peptides in cycles. And when we talk about cycles, we're talking about maybe 6 weeks to 3 months. That's one cycle. And then you come off of that peptide and you add something different based on what the different needs of your body might be, either for that season, for that training period, just to readjust what your body's doing so it doesn't get too, the receptors don't become too used to what you're putting into it.
So whenever you say stack, do you mean, you don't mean doing them at the same time? You mean doing one in succession to another? I mean, so one after the other is that what you mean whenever you refer
So a
to
stack would be more than one peptide. So for example, my current stack is tesamorelin, oxytocin. I'm using BPC intermittently for injury, and what else is on there? Melanotan 2. You can use that's my stack currently. And then in 2 more months or so, I'll adjust that stack to whatever the next combination might be. I might switch over to CJC IPA. I might take my oxytocin out and put some VIP in. Just it depends on where I am in my training cycle and in my own life at the time.
Yeah. Also, an important point for anybody listening, peptides, and you make this point in your book, which I think is really important. If you're a metabolic mess and you generally don't have fertile soil for a peptide to really function well. So if you've got other issues to deal with, like, you're crazy inflamed or whatever, or you're insulin resistant to the hilt or things like that. I mean, or you're not sleeping well and you have other issues, then kind of got to get some of that stuff kind of straightened out, because the people who respond very well are the people like the guy I just mentioned. But anyway, that's my experience, but I think that's a good point.
Yes. Always got to work on gut issues. Always got to decrease that inflammatory process. Think about your teeth. That's always where I go with patients. Teeth, intestines, sinuses. Those are places where we'll commonly see people have things that are contributing, looking for things like cytomegalovirus, like Epstein-Barr virus, other things that might be contributing to inflammation in general. And then always consider, even if you're not symptomatic from a root canal, always consider having it CT'd. Look at with a cone CT. Plain X-ray doesn't always pick it up. I've had 2 patients right now who we've had unidentifiable inflammation, and we've gone back and cone CT'd their root canal, and there was an abscess in that tooth. And that fixing that problem then allowed us to go back and treat the patients, and they did respond well. So for example, if you're listening to people that are not responding to the GLP-1, sometimes that inflammatory process or an intestinal problem may be the culprit, and we need to readjust our focus from performance to anti-inflammation, and then we can hit the performance after the inflammation's under control.
Yeah. Have you seen, speaking of dental inflammation, and this is a sort of off topic, I've got a client in another state that he has these high lipids all the time. And so I send him to see a biologic dentist to really dig in here and really get some images like what you're saying. And sure enough, he did have a finding. So we're hoping to resolve some of that anyway, have you seen patients like that where they have inflammation in their, and then lipids turn around once all that gets calmed down and treated?
Absolutely. CRPs in the 10s, and you get them off, that you fix their teeth, and then they, and you're trying to do all the things of to bring their CRP down with LDN and fish oil or SPM, pro-resolving mediators or whatever, and they're not responding, Bullyoak. They're not responding to those things, and all of a sudden you say, hey, let's go look for something specific. You either find CMV or you find a dental issue. Yes, definitely. You can get them to bring their, cholesterol is an inflammatory response in many cases.
Yeah. Well, let's talk about what you're doing now, because people who don't know you, if they're seeing you right now, they think, oh, she's smart and very, put together, but they don't know that you're a beast in the gym. I've seen you deadlift and the stuff you post on Instagram over the past few years, and just crushing it. So, and then competing as well, right?
Yes. I haven't competed in over a year, but yes, I was a competitive powerlifter.
Yeah. And but now you're getting into more bodybuilding or something, I think.
Exactly. Right? Yep.
Yeah. Well, cool. Are you planning on doing any more any more competitive things in that regard or no?
Oh, no, probably not competitive bodybuilding. I think there's a lot of, I think the requirement for the diet being so restrictive
Yeah.
is cortisol inducing. I'm not sure it's the healthiest
Right.
for the competitor. And so, although I respect what they do and appreciate it, I think it's probably not the best choice for me.
Yeah, it can be really hard on anybody. It's just you got to really love it. You got to really want to scratch that itch to go down that path. But
Yes, I do love weightlifting, and that's a lot of fun. And I love the powerlifting, and that was fun too. And I still do that, but just not at the competitive level.
right, right. So what is your? I mean, you just briefly said what your. So what's your regimen? What's your stack? Tell me that again. What do you?
So
what do you
I usually train 4 days a week, about 2 hours, and hour and a half, 2 hours. And then, like I said, I use tesamorelin. I try to use that. You know, you can use it up to 6 days a week, but I'm using it just 4 days a week. So just training days. I'm using rapamycin once a week on the off day. I use GLP-1 at a super low dose for cognitive function. If you haven't read about, I know you have, but if your audience hasn't read about the really great brain anti-inflammatory, and it was originally studied in Parkinson and dementia patients, and they found that the patients lost too much weight. So they flipped around and said, wow, this might be our cash cow, and turned it into a weight loss and diabetes drug. But the original research was in dementia. And so that's one of the reasons why I use it. I want to make sure I can continue to use my brain as long as possible. And so I'm microdosing about every 10 days just to maintain that GLP-1 level. And there's no specific regimen there, but my regimen is that really low dose, probably once every 10 days. And then I use testosterone and estradiol. I do those injectable in a sub-Q manner. I do those about every 10 days as well.
Do you inject both of those
I
combined?
do.
Okay.
I do. Yep. I had pellets at one time, and I felt like I didn't have the control over the dosing like I like to have.
Yeah.
So I went to doing injections instead of every 3 months. You know, you sort of get this long high peak with that pellet, which is great for some people, but it didn't. I'm here in the office. I have easy access to using whatever. So I do it. If I'm noticing my signal that I need to take some more estrogen is I get out of migraines. And so I just wait till I start feeling that. And then I get a little, oh yeah, I probably missed my estrogen. It's probably due for my estrogen this week. And then I do, as I mentioned, oxytocin. The weight loss dosing is 4 days, 4 times, based on the research, is 4 times a day before meals in bed. And then the dose for muscle mass gain is immediately post-workout. About 40 international units of oxytocin.
Yeah. Do you use that like sublingual or?
I am. Sub-Q. And I've heard stories about people having uterine contraction. Obviously, that would be something you would look for or expect because it's one of the reasons we use it. But I've not experienced that to this date. And I use that 4 days a week. So then also melanotan. And you can see it doesn't tan me very much.
Yeah.
It really, for me, requires sun exposure to get that effect. So I don't have that unless I'm out in the sun. I have fairly light skin. And again, that's something that I use about 4 days a week. So on training days, I don't usually use it on non-training days. And the reason for that is just, I feel like I'm doing something different on my training days than my non-training days. And I don't want to, there's no science behind this theory. It's just the way I found that my body responds well to it. I think if I use tesamorelin more often than 4 days a week, I start to get swelling in my hands. So I use it, that sort of carpal tunnel-y symptom. And so then I back off to 4 days a week instead. If I'm using it consistently, that 4 days a week, my recovery is great. I can go back to sport, 2 days later, I'm not overtraining. Yeah, it works really well. Good body composition, good training recovery. So I like that regimen.
Yeah. Yeah. For recovery, that's when it comes to, peptides and training and competition, it seems to me the overwhelming theme is really accurate or quick, solid recovery.
Yes.
Which is huge. So, yeah.
And the tough part for most of us, especially women, I think, is we don't eat enough because there's that terrible balance in our brains about being thin enough, whatever that is.
Right, right.
And so there's this fear of eating too much because you might gain weight. And what's interesting is there's a study that came, I believe it was out of Shands recently under Dr. Bill Campbell. And they added 300 calories a day of protein only to these trained female athletes' diet. And no one gained weight. Not one.
Wow.
Yeah,
Were they,
pretty impressive.
yeah.
300 calories a day of protein added to the diet. So this is why we're very, very strict in our practice with our athletes and our weight loss patients on how much protein they take in a day.
Yeah. Yeah. Same thing. I mean, especially if we're using the GLP-1 agonist, we do DEXA scans regularly to follow that body composition, every 4 months or so.
Well, and don't forget the unsung heroes of weight loss is that melanotan and the oxytocin. There really is some great side benefit with using those peptides as well. So a great stack might include those and some AOD, especially since AOD is coming back to our availability, which is really great.
Yeah. I've never used oxytocin for weight loss.
Yeah, I think there's a human study out there. It has only 12 patients, but they used it 4 times a day before meals and bedtime, and all of them lost weight. So should be part of it's mostly body comp, but you're going to muscle gain. If you're doing the resistance exercise, you're going to gain muscle and lose fat. But because it is very anabolic. It is.
Do you think a part of that is from just getting somebody out of the sympathetic overdrive, helping them relax and kind of come back down? Do you think that, getting the cortisol levels down to help or
it's certainly part of it, but it has a direct effect on muscle to increase fat burning. So yes.
Huh.
And look up the bone density research on oxytocin. So a nice stack for bone density might be BPC and TB4 and oxytocin.
Yeah. Huh. Well, that's cool. I feel like I'm just learning things. This is really about me then, is what this is. Okay. Or about my patients as well. The GLP-1 agonist, I'm hearing a lot of the microdosing stuff, and I'm not very familiar with that. I haven't used that in our clients at all for the reasons that, for cognitive benefit. It certainly doesn't make sense. Have you noticed just personally more clarity or anything? Obviously you have, or you wouldn't be doing it, but.
And for your weight loss patients who are having trouble with the side effects, that can also be a way to mitigate some of the side effects is by decreasing their dose and dosing it more often, either twice or 3 times a week with a very tiny dose. Yeah. Often they'll be able to get rid of those really unpleasant side effects. Of course, using something like the tirzepatide or cagrilintide treatments for as weight loss, the cagrilintide has some pretty strong side effects too, but the tirzepatide has way less side effects than the others. So you can get away with using that one instead. But if you're the most effective, if you're using the semaglutide and you're going to deal with people having insomnia, constipation, nausea, turning that dose down and dosing it twice or 3 times a week may be a good solution. You could always go back to the daily dosed Victoza or whatever. It's a liraglutide.
Yeah. And you're taking the rapamycin, which I've done. A few rounds of that, and that's really exciting stuff. One thing I did notice on that is and whenever I did that, I wasn't doing any other peptides or anything else, so I did notice a really decrease in inflammation. I had this arthritic, more of a tendonitis thing. I was probably lifting, not letting myself recover, but that kind of just went away. There were some other interesting findings. So do you take that just regularly, or do you kind of cycle on and off of that, the rapamycin?
I actually cycle on and off, and I do it just weekly. How are you dosing it?
6 milligrams once a week. Yeah. Just weekly for about 6 weeks. So that's really exciting. I don't know. I guess we should explain what that is. It's a whole different podcast topic, but it's an mTOR inhibitor, nutrient sensing, shown to be really linked to longevity and all that. But anyway, I've done podcasts with Matt Chamberlain, and we get really deep into that. So that's a lot of fun.
It's a good option.
Yeah. Yeah.
It's a good option. I'm just thinking if I'm spending the week doing everything for bodybuilding, I'm adding protein, I'm doing lots of resistance training. My body is working toward mTOR positive. I'm eating, consistent with my workouts. Yeah. If all of that is mTOR focused, then on my break, I want to make sure that part of my recovery is really giving it the opportunity for autophagy, for turning down that heavy, add some spermidine, really giving the opportunity for AMPK to take over, increasing the number of mitochondria that my cells are making, so that now I can go into my following week with a really nice load of mitochondria to have the energy to be able to do the rest of the week again with that high mTOR state, and then do the break with the rapamycin on the weekend.
Yeah. How long have you been taking the tesmorelin? Do you take that? Do you take ipamorelin some and CJ?
Yes. Probably 7 years.
Okay. Yeah.
Yeah.
Well,
I
you're
would
not.
guess.
Yeah. All right. Well, cool. Well, I want to be respectful of your time, and I know we've been chatting and I could sit here and just shoot the bull with you all day, but I do want to I want you to explain to me this other topic that we've been talking about, because like we said before we started recording, I do have this patient who did the procaine stellate ganglion block, and kind of the basic overview of how those things work and getting people out, treating PTSD and some other things, and just getting people out of that sympathetic drive. So anyway, explain to me. Go.
Sure. So I love peptides. I think they're awesome, and they certainly have their place, but this has been a real game changer for our practice as well. Like, I remember when peptides, we were first introduced to peptides, 7 to 10 years ago, and wow, so exciting. So many patients got better. And this is the next level for me in helping patients, or the next thing for me in helping patients to get better. So neural therapy is a century-old practice that's been used for obviously a very long time. Most of the practitioners are in Germany and South America. And the research, so if you think about the original the original anesthetics for surgery was cocaine. People in the 90s used cocaine.
Right.
Well, cocaine had the side effect of addiction. And so they transformed the chemical cocaine into procaine. It was the original. None of the others are the same chemical makeup. Lidocaine, bupivacaine, tetracaine, all the ones we know of now are all different chemical makeup than the original procaine. So the procaine has this unique ability it converts into two different metabolites. One's called PABA, the other's called DEAE. And the two of them work in the cells at really interesting ways. They increase blood flow to an area of damage. So let's say that you have a chronic tendonitis, for example. The body is going to decrease blood flow to that area after a time. Initially, you'll have an increase in blood flow. Everything will be there. But over time, that area is going to get a decrease in blood flow. It's not going to be dramatic. You're not going to become necrotic, but the body's going to sort of put that aside and not give a lot of its energy because it's not being fruitfully restored. It's also the cells are going to, like a battery, like a battery that's lost its charge, is going to change its electrical charge. So a normal cell is at, say, negative 70 millivolts. A damaged cell is at something like negative 40 millivolts. So in order to restore that charge so that the cell can actually receive nutrients, remove toxins and infection from itself, we need to have that charge restored. And so those are the two things that we know that procaine, as opposed to the other local anesthetics, does. So let's talk a little bit of physiology, right? The body has two different nervous systems. One is the somatic, meaning I'm going to go pick up this coffee cup. I'm holding it. I grab it with my hand. I'm asking with my brain, my fingers to close on it with grip. This other nervous system is the autonomic nervous system. That's what runs when you walk outside in a bright light, it causes your eyeballs to constrict. It causes your heart to speed up when you're exercising. And that's the autonomic nervous system. It's not under your cognitive control. Your brain isn't thinking to make it happen. And so the autonomic nervous system has two divisions. That is the fight or flight response and the rest and digest response. That's sympathetic and parasympathetic. And these two nervous systems innervate all of the organs of the body, as well as the fascia and some of the muscles, or most of the muscles in the body. We want these two to be in a beautiful symbiotic balance where you have both sympathetic and parasympathetic working in conjunction to provide the body with what it needs under varying circumstances. So for example, you're walking down a dark alley, you hear a noise behind you, you get a little bit scared, you feel that fight or flight response kick in. You turn around and you say, it's my significant other, hooray. You give them a big hug, your heart rate blood pressure comes down, you go into your normal function, you give them a hug, and you go about your evening together. If that wasn't happening, you would stay in this, oh my gosh, and the whole entire night would be ruined because you'd be so upset about hearing a noise behind you and not knowing what it was, and that persists. And of course, we have lots of patients who have that situation happening either because of PTSD or because of some sort of complex PTSD with a childhood trauma, or even people who go for long periods of time without sleeping, or especially, I would say recently, with the unexpected viral illness that we had several years ago that changed the way the entire world works and the way we all think about the world. We're doing way more talks like this and way less in-person, handshake, giving each other hugs. And so there's a lot of sympathetic drive that goes on anyway. So when that sympathetic nervous system is the dominant nervous system, lots of disease states come out. So all the research that's coming, lots of research is coming out right now demonstrating heart disease, kidney disease, et cetera, and neurodegenerative diseases are a lot related to the dominance of the sympathetic nervous system in the body. We know that from studying peptides with the way that dihexa works, for example. One of the ways that it works is by changing that response to the sympathetic nervous system. So it doesn't change the drive, but it does change the response. So we know that we can so in the United States for a while, we've been doing what I call the American stellate ganglion block. And that is very different from what I do in my office. This American stellate ganglion block is lidocaine plus steroids, or they use bupivacaine, which is very long acting, plus a steroid. It's done under fluoroscopy. It's done in a lab setup with drapes and the whole bit. That's typically done by a pain specialist, an anesthesiologist who's been trained in interventions, and they will do that stellate ganglion block that way. Well, the research shows that the stellate ganglion block done under fluoroscopy or under landmarks only, which is what we use. There's a specific landmarks in the body that we look for. And the stellate's really easy to find. It's right behind this great big muscle called the sternocleidomastoid. It just lives right behind that muscle, right in front of the cervical spine. Your cervical spine's right here. Sternocleidomastoid is right there. And so you can get right behind there, and that's where it's located. And there's a specific thing that you feel for looking for how to do this. It's very simple. We use a 30 gauge needle and a little 1/2 inch long. It's nothing. And patients are in and out in 15 minutes after their initial visit. It's a very quick procedure. They pop in, get their stellate, go about their business. We like them to hang around for about 15 or 20 minutes afterward because they will become euphoric. They'll feel calm. Some people will say the word safe. I have people that will burst into tears. They haven't cried in 10 years and they burst into tears when they get their stellate. We do other ganglions as well. So if you have a lot of intestinal symptoms, the celiac ganglion controls all of the intestinal area. And so we'll infiltrate the celiac ganglion with procaine. That just temporarily turns down that sympathetic drive. The stellate is in charge of everything from the diaphragm to the top of the head. The celiac is in charge of everything from the diaphragm to the top of the pelvis. And then there's 2 ganglion in the pelvis, the inferior hypogastrics, and we can treat those, and they do a lot of things. So we know that benign prostatic hypertrophy, for example, is a sympathetic dominant state. And a lot of men will respond. They'll come back the next day after their stellate and their inferior hypogastric and say, wow, I peed like a 14-year-old yesterday.
Really?
So it's pretty impressive to see some of the results. Yeah, it's pretty exciting. So there's lots of things out there that we can do, that we can treat with this. And a lot of our patients have gotten some significant relief. We have some stories of recovery of anosmia from viral illness. We have recovery of ringing in the ears for some people, of Meniere's disease being significantly improved, people being able to go fly on airplanes for their job where they couldn't do that before, people being able to go back to work. I have an agoraphobic patient who's been able to go back to work 4 days a week and is thinking about starting dating. So really exciting. She couldn't even drive herself anywhere to the grocery store, nowhere before. And because of motion and light and sound sensitivity. And after about 12 treatments, she drove herself to her visit.
Where did you treat her at the stellate ganglion, or where did you?
I did.
Really? Just one treatment?
No, she had about 12 weekly treatments.
Okay.
Yeah.
Okay. Wow, that's kind of life changing. No wonder you were
Yeah,
so giddy when I was talking to you about it whenever we connected about a month ago.
it's pretty
Uh,
exciting.
yeah.
Yeah, we're having, it's a lot of, it just requires you to be very specific and know exactly where your landmarks are, and then know how to engage with the patients. There's a unique formula of things that we do that help with engaging with these patients, because a lot of these patients have been through a lot of trauma. So the last thing you want to do is trigger them again to have more problems. And just like, I'm sure you've ever prescribed Xanax in your life to a client, but just like when you give them Xanax and they can throw it off, if their sympathetic drive is strong enough, they
Hmm.
can throw this stellate off as well. So you have to prepare them to be able to receive the treatment, for example. And this one patient I mentioned with the agoraphobia, she had been to a pain anesthesiologist, pain specialist, and gotten the standard American stellate block and had not responded to that at all. And when we treated her, she did. So you're going to get a big Horner response. This is the weird thing that people are worried about, and it's fine. So what happens is the sympathetic nervous system, when it gets turned down, the sympathetic controls a lot of the function of the face, a lot of the muscles of the face. So you'll have them have sort of a heaviness in this side of their eye, a heaviness in this side of their mouth. They will flush, their skin will flush, kind of like when you take niacin.
Hmm.
They will start to move their bowels. You'll hear their borborygmus, or their bowels move, the movement of their bowels start. So
Yeah.
people who've been constipated for a while will start to have that happen. Most people come back and say they slept like a baby the night after the treatment, and sometimes 2 or 3 nights after the treatment. The treatments build on one another, so we do one and then we do another and then we do another. A lot of the pain doctors will use ropivacaine so they can avoid doing the weekly treatments. The problem with ropivacaine is you're not getting the DEAE, you're not getting the PABA that's required. Those are the metabolites of procaine that are required for the restoration of function, for the cellular restoration of the parasympathetic nervous system that you get with procaine. You don't get that with ropivacaine. So you do get a prolonged blocking. So the first treatment with ropivacaine will last several weeks, but that one does have to be done under fluoroscopy or some sort of imaging, because if by chance it gets accidentally put into the carotid, it's a big deal. Whereas a little bit of procaine is not a big deal. It's
Yeah.
short acting. People do well.
And your injections are really small, like you said, like a half inch,
Tiny.
tiny. So okay. And you're actually teaching clinicians on how to do this with a few little modules or whatever you would call them out there at your office, at your clinic.
Absolutely. This coming Friday is we did our beta test about 3 or 4 weeks ago,
Yeah.
and then our beta training. And then we're here this coming weekend. We're doing it at our office in Atlanta. And we're excited that it's full. It's going to be a hands-on training. So half the day of didactics and half the day of actually physically learning on each other how it feels and how to do it on other people. I mean, with what we talk all the time about what the patients have been through with the pandemic that happened a few years ago, but we forget what the providers went through, and especially providers like me, I think you as well, we never closed our doors. We were open the entire time treating COVID patients. And so not having that time to rest, and we are, as healers and caregivers, we certainly have the risk of becoming a sympathetic overdrive ourselves. And so this is, physician heal thyself. That is part of what we're doing this weekend too, is allowing the providers who are coming to the retreat or to the conference to actually be able to receive the therapies as well as administer them. So the expectation is by the end of the weekend, they will be able to go home on Monday morning and administer them to their patients in their offices.
Okay. Wow. Tell me again. Now I'm going to get just kind of, as you share all this information, I'm just thinking about specific cases.
Of course.
Like I've got and this is more common than I ever anticipated. People who have had loose stools for like, say, 20 years, 25 years. And it always has to do with if they're in a car traveling, or if they're in a place where they can't get to a bathroom, and they've had GI workups and colonoscopies and all this stuff, and you know where I'm going with this, but it's always, it's very debilitating. Like they can't get in a car with their friends and go on a trip, or can't go on, but if they're at home, or if they know they have a comfortable area where they have a bathroom, they don't have any problem. They don't have any symptoms. So like you said, I assume this could be treatment, you could do this kind of treatment for that kind of stuff.
It can be life-giving. It's really amazing. And we've seen transformation after transformation in a lot of our patients. So it's exciting. We can treat some chronic back pain, some chronic sinusitis. We do one treatment of the sphenopalatine ganglion, which sits sort of, if I draw a line between my two fingers, it's right there. It sits sort of back in there, and you can access it over the zygomatic arch. Yeah. And so infiltrating that ganglion with some protein can really help with a chronic sinusitis. There's a lot of things we can do that can be useful for these types of cases. And that can be, I've had this for for years and years, and it's all better now because of what you're doing. So it's kind of exciting to have. It doesn't work in everybody. We certainly, wouldn't claim that, but we have some really great cases where patients have had awful symptoms. So it often will work in places where what we'll do is infiltrate the scars, because we often ignore the benefits of the fascia or forget about what fascia does for us. And it's not just a covering, it's actually an information superhighway. So if you don't know, fascia is the covering over all of our muscles of the body. So kind of underneath your skin, underneath the fat layer, is this covering body stocking, for example. And it's innervated all different directions. So when you have surgery, that body stocking gets cut. So a lot of the nerves get cut. And you may know this from your own skin sensation, but some of the more important, deeper nerves get cut as well. And that can cause pain in other areas. So you might have a left great toe pain that's because of your C-section scar, or a shoulder pain that just won't go away, and it's because of the scar you sustained on the knee from arthroscopy back in whatever year. Or even the little vaccine scars that we get from probably not you or me, but years before us, that got from smallpox. Even that vaccine scar can create an interference field that can cause difficulty with communication. So now blood supply doesn't happen, and nutrient delivery doesn't happen, and trash removal doesn't happen. And so the cells of that area can do poorly because of that. And it can be in a very remote area from there. We talked earlier about dental problems and how a root canal or other problem can create an inflammatory process that is felt in the entire body. The same thing happens. Often we can treat those teeth with a little bit of procaine and maybe even add some ozone. And wow, their years of left knee osteoarthritis goes away, because they've had this inflammatory process ongoing for many years. So if we can decrease their inflammation, then that sympathetic nervous system calms down, and things like osteoarthritis improve.
Mm-hmm. Well, I need to get down there and dig in on this. I won't be there this weekend, but you're going to probably have another one in February, you said? Hopefully.
Yes, exactly. We'll put it on the website, but we're excited about having it. We already have a waiting list for our February conference, so that's exciting to have. We haven't scheduled a day for it, but as soon as we get that going, we're excited to be able to teach and to be able to bring this out to more people than just us. Kind of create a community of people that can, as you know, having a private practice, you tend to be a little bit isolated. So it's really great. Your podcast is a perfect example of where we get to share ideas, and we get to meld our, and then just sort of feel like you have something in common with a medical entrepreneur who's doing big things in the world. It's fun to be able to communicate with you and to be able to share that information. So I appreciate you inviting me on the podcast today.
Sure. Thanks for being here. I could talk all day and pick your brain. I'd love to, go off on hormones and all that stuff at some point, but especially dealing with women. But well, is there anything else you want to share at all that you think is important before we kind of wrap things up?
Well, briefly speaking about hormones, I do think it's fun one of the things that's really important is making sure that your hormones are balanced before you think about those peptides. Mm-hmm. So getting your gut straight, getting your hormones balanced, and then adding peptides as the top layer. We, in general, as humans, forget our tremendous contribution to the world, and forget that what we contribute to the world is our, as women, I would say we contribute our beauty, our nurturing, our creativity. As men, you contribute your confidence, your protection, your I'm trying to think of another word that feels right there. You are unable to, the providing, that's the other word. Your protection and providing, you're unable to be that protector provider. I'm unable to be that beauty creator, nurturer, if I'm not doing the things that I need to do to take care of me. So where in my life do I need to make some adjustments to be sure that I'm taking care of me? Because if I'm taking care of everyone else before me, I'm telling myself how unimportant I am, and I'm driving that sympathetic drive. I'm decreasing my body's ability to recover. So if you're seeing that you're having trouble recover, start there. This is not a medical thing, but it is medical because it's very related to how your body responds. So if you are taking the time to take care of you first and making you a priority, let's say, for example, you're a mom and you're going for the weekend and you have plans for the weekend and you really want to play tennis, but you have something else happen with the family that you need to take care of, and you cancel your own plans to go and do the thing that needs to be taken care of. There's an element of losing the opportunity to be the person your family needs from you if you're not doing those things that take care of you. So making yourself a priority is really important. And that's a big part of what we talk about in our clinic is what things do we need to change and how do I help you to cut things out so that you're making yourself a priority.
Yeah, that's a common thing. Even with our intake form, a common theme that I'll see is their self-care will be 2 out of 5. I mean,
Yes.
It's always on the lower side of things. That's kind of the first thing that, people let go, which is, yeah, like you said, and you make a good point on that in the book, how important that is, because you can't show up for other people if you don't take care of yourself. So,
yes.
And people think of being selfish, but you're not being selfish. You're actually, giving to other people if you, invest in yourself. So anyway.
That's all. And that's the sort of bottom layer. And then we add on top of that the hormones, we add on top of that the gut health, we add on top of that the peptides, and everything works.
Yeah. Yeah. Well, cool. Well, I would recommend everyone grab your book. I didn't know what my expectation was, but when I opened it up and it was like a story about one of your patients and everything, I think it's just really well done. So,
Oh, thank you so much. I appreciate you, Kevin. That's great.
Yeah. Well, I think that's it. Do you have anything else to share? Anything else that you think is important for everybody to know?
Nope. Thank you so much for having me today. I really appreciate you.
Absolutely. And thanks for making the time. I'll see you.
My pleasure.
Okay. See you later.